Urological Art Award. Sorry, please. Yes. Cook Urological Art Award was established by Cook Medical in honor of Dr. Arthur Smith in 2004. This award is awarded to urologists within 10 years of completing residency or fellowship who has achieved distinction through myriad contribution to the field of endourology in research and teaching. The first recipient of the award in 2004 was exception, Dr. Arthur Smith himself, and the recipients of the following years are shown here. The illuminated and beautiful illustrated glass block award is presented to the awardee. Ladies and gentlemen, the recipient of Cook Urological Art Award this year is Dr. Mahesh Desai, the University of Southern California, the United States. Dr. Desai graduated from Gujarat University, India, and had laparoscopic and robotic fellowships at Cleveland Clinic from 2000 to 2003. He became the director of the Center for Endourology at Cleveland Clinic and moved to the University of Southern California in 2009 as Professor of Urology and Director of Robotic Urologic Surgery. Dr. Desai's innovative work includes pioneering novel flexible robotic platforms, natural orifice surgery, and single-port laparoscopic surgery for various urological conditions. He has published over 200 manuscripts in peer-reviewed literature on these topics. Miho, come up to the stage. And the presenter is Mr. Jean-Marc Cresel from Cook.
Thank you, Professor Matsuda, and I really thank the Endourological Society for this extreme honor. I think it's a privilege. I've seen the illustrious recipients of the past, and more importantly, a formal way of getting Dr. Smith, who's really been the backbone of the society, attached with me. I never formally trained with him, but I've always regarded Arthur and Kay as good friends, good mentors, and I truly value, and one of the best things of my career is having the privilege to knowing Arthur and Kay, and indeed it's a privilege and honor. I have selected as my just a brief presentation something that is exciting us now at USC, focusing on robotics for treatment of invasive bladder cancer, at probably the mecca for bladder cancer surgery, wherein the bar has been set very high, and really this may be a final frontier for robotic and laparoscopic surgery. As you know, the evolution of the minimal invasive cystectomy, I was fortunate to be involved when the initial laparoscopic cystectomies were performed when we were at Cleveland Clinic, and from laparoscopy we moved to robotics, but still the most important reconstructive part of the operation, which was the diversion, is still being performed extracorporeally. Mainly for time limitations, but however, if this has to succeed as a mainstay treatment, I think the entire operation needs to be intracorporeal and time efficient. As David Wood mentioned in his editorial on a paper on radical cystectomy, that the ability to make this a completely minimally invasive procedure is going to be what will set the bar. And essentially the reason why it has taken this while for this all to come together is that this is not just one operation, but we believe is actually 3 independent operations, which is a cystectomy, node dissection, and diversion. And while in the earlier years we were trying to demonstrate technical feasibility, at least reassure ourselves that the oncologic efficacy was equivalent for this otherwise potentially lethal disease. Now that these first two steps have been reasonably accomplished, now we can focus on how to incorporate the diversion as a time-efficient manner. And again, urinary diversion intracorporeally is not new, and pioneering work by Khurshid Guru, Raj Pruthi, and more recently Peter Wickland from Sweden has given again the resurgence for this approach. What we've tried to do at USC is to basically develop a reproducible and time-efficient technique without changing the actual configuration of the intracorporeal reservoir or neobladder whatsoever. And so essentially we take the same segment of loop, do the exact same detubularization, and do a perfect spherical reconstruction as described by Studer in his work. Our experience now with intracorporeal diversion is about 65 cases, and the way we approached this was we first did the first 15 at USC of the technique, and then we were fortunate to have international collaborations, one in China with 2 hospitals, and the hospital in India at Nadia, where we did 19 cases in a relatively short time. And then since our return, we have then further consolidated the technique with about 31 cases in 6 months, and really also focused on developing extended clinical care pathways. And again, to folks emphasize that this is a team effort, and really a lot of work has been put in by everybody there at USC and with our international collaborators for making such an extensive procedure feasible. And really, we have data on the initial 41 cases. I don't want to elaborate the actual details, but just to say that our initial results from a cancer standpoint have been really encouraging, and the complication rates, though exist in this otherwise difficult and to treat population group, certainly appear to be reasonable. Our node count oncologic efficacy surrogates appear to be similar, and focusing more on timing, there has definitely been a reduction in the operating time. Mainly the cystectomy and node dissection really have been 1 hour each procedures, and the reconstructive times are also coming down. And just to show the impact of how international collaboration can work for really pushing certain areas forward, since we were doing these in back-to-back days, our OR times literally came down to under 5 hours on the console for the neobladders, thus again putting enthusiasm in an otherwise operation where everybody would go, my God, not another cystectomy today. And so I really feel that this may be what will allow us to really get volumes to demonstrate in the more important questions of oncologic data. So currently we offer this to most patients with muscle-invasive bladder cancer who require a cystectomy. Intracorporeal neobladder, the functional data and the oncologic data are awaited, and a prospective randomized trial with a completely intracorporeal technique versus open surgery is currently being instituted at USC. Finally, I'd like to end that it's not that everybody is fortunate to have mentors that can really give you the opportunity and support. I have been lucky in my career that I have found in Indy Gill a mentor who has really not just taught me the art of surgery, but really has pushed me to what I think I can achieve. Again, I would like to thank my parents who have been always supportive, and I could not have had better role models in my career. But I think the award, in my mind, truly goes to my son and wife, whose hard work and sacrifice is really what made this possible. Thank you very much again for this honor.